Thank you very much for inviting. Actually, so I was excited coming here. It's a new community, but listening to the talks made it even more, fulfilling. That yes, I knew that I was coming here, of course, to share our experiences, but also to learn a lot. And I have been doing that learning. It's been very, very useful. Thank you. So. I think what I'll be going through is, so because this is my first time, and hopefully I'll get to see you guys later again, what I was thinking was introducing our community, our program to you. And so it'll be a broad talk, but I can sort of go deep as the questions come. There's maybe too much material, I realize. It's not a 20-25 minutes talk, it's more than that, but we will modulate it. So, so this is a joint program. Actually, let me get to the next slide. So the Connected Health program, I started it about 3 years back with the help of my colleagues from Jacobs School of Engineering at UC San Diego, but also across the campus, School of Medicine, School of Public Health, Psychiatry. So, you'll get to see some of the projects, and this is what our vision is. And I hope that all of my colleagues share the vision, but this is what the vision that we are promoting. And the good thing is that we have some interesting partners who believe in that vision. So Kaiser Permanente has been a fantastic partner, UC San Diego Health, of course, and we have been in conversations with various other hospital systems which I have not listed here. What I've listed, and maybe I should have listed others, what I've listed are really our sponsors. So what our vision is to use, so though some of our faculty are developing various interesting kind of sensors, and I was listening very, very attentively to David and what David was summarizing, I did not realize that there was this very interesting summit in San Diego, otherwise I would have definitely attended it. But so we have a lot of faculty working on various kinds of sensors. They are developing various kinds of sensors. Unfortunately, in our program, we are not being able to use those sensors yet because, as you'll see, that most of our programs are going towards actual patient study. So we need FDA-approved devices. But we are having ways of using those sensors as they are being developed also in our program. So the focus of our program is to move from where we are today to the future. Today, I don't know whether all of you are like this, but at least myself, I go to the doctor only if I really need something. I hear a lot about preventative, but I do things myself at home, at work, on travel, but I'm seeing my physicians only when needed, and I forget about them and they forget about me as soon as I walk out of that office. And again, if something happens, I reactively again go to them 6 months, 1 year, 2 years, fortunate. Hopefully, as long as I cannot see them is what I try to do. They have no way of monitoring what I am doing or not doing. Am I complying with some of the feedback that I received at their office? Whereas what we want to go to, and this will be made possible by all the, what I'm calling Internet of Medical Things. Internet of Medical Things to me comprises of all the different kinds of wireless sensors which are being more and more connected to the internet, either between themselves or to the regular internet, all the applications, and all the more and more medical devices, imaging devices are becoming smaller and smaller and getting connected. So that class of devices that are emerging, we want to use them for a much more proactive, personalized care, but also which is affordable and which enables continuous engagement, patient engagement, and very, very importantly, compliance with whether the patient is doing the right things, what the effectiveness are, and so on. So this is the future that we want to build. And as I mentioned, that I have been fortunate to attend some of the, for instance, white hat workshops developed by Kaiser and others, where this is what we talk about, that how can we disrupt the system that is today? How can Kaiser and others move towards a different kind of system, where yes, data is owned by patients, and many, many other disruptions which we might discuss while we go forward. The reason I mentioned about data is because of what I heard from David's discussion in that forum. So one of our mottos, one of our goals is we will enable this personalized, affordable, continuous, but at the same time very, very conscious of cost. So we will enable better quality care, at the same time drive down cost. It might look sound very counterintuitive, right? But actually we can do it because the cost will go down because of the kind of care that will be provided eventually. It will not need as much intervention. It will be much more virtual care and yet much more effective. And to enable that, it's not only the IoMTs, but also the multimodal fusion. There is much work going on, not just at UCSD, everywhere, about fusing data. I think one of the speakers mentioned about these various different kinds of sensors and devices, and so those will be providing various different kinds of data. So the field of multimodal fusion and multimodal data analytics is going to mature more and more, and we are contributing towards that. Machine vision is very important. We hear about AI, but machine vision is becoming more and more part of AI. And we are the Center for Wireless Communications. So we obviously specialize in 5G technologies, both in terms of computing and communications. And I would not have as much time today to focus on those, but we are doing a lot of innovations to enable this kind of connected health. And that's why we call it connected health and not digital health, with those innovations in 5G computing and communication. So, what I'll be doing is I'll be briefly introducing. The first one I'll go into a little more details because I thought that this was more relevant to this group here. And then I'll introduce two other projects later on, but keep it very brief. So this particular project is all about virtual care analytics, we call it. And what we want to do is have a system. We are developing the system which can continuously monitor various kinds of vitals. This is what we do today, but we want to increase the kind of vitals that we are monitoring, and also behavior. Today, as you see right here, one of the very important pieces that is missing is nutrition, and that's why I'm here to learn, and to cooperate to see how we can incorporate it. But what we are monitoring today are sleep and exercise, and also contextual data is extremely important. There was a brief discussion. I think Chor asked the question about time of exercise. I'll give you anecdotal evidence. I don't know what the answer is, but I'll give you an evidence which points that might be important. So we are also gathering various kinds of contextual data as we do our studies. I will not go into the details of the artificial intelligence algorithms that we are developing, but I wanted to hit on a couple of key points here. So the world keeps talking of big data, right? And actually what we are seeing more and more is health data is not necessarily big data. It's very, very nuanced data. It's a lot of error-prone data. Very important to note is it's time series data, and a lot of artificial intelligence techniques are not good with time series data. So for instance, one of the things we found out that, I'm sorry, to just back off a little bit. So our goal is to develop machine learning models which can predict, for instance, in this case, it can predict what your blood pressure will be given your activities, your sleep patterns, and your historical blood pressure. Same thing we want to do for other things. Now, why this prediction? Because through this prediction, we can provide you personalized recommendations. We can tell you that for Sujit, the important factors are 1, 2, 3. For someone else, the important factors are 3, 4, 5. So we can tell you very precisely what those factors might be, and this is using data. This is not even using biome and other things, which definitely should be added, but at this time we are not doing it. So this is all using data, all evidence-based observations, that what factors are more important for you as opposed to others, of all these other factors that we are collecting, features we call them. Now, so going back to sort of the discussion about data and machine intelligence techniques, recognizing that this data is time series has been extremely important. So for instance, if we do not add the time of the day, days, mornings, evenings, nights, we are getting much lower accuracy in the prediction models. Does that answer your question? I don't know. I don't know whether that answers the question directly, but one of my missions here is to collect all these questions so that we can put them in our platform. See, what we have developed is a platform, and we can ask the right questions in that platform and then answer those questions. So recognizing that these are time series data, recognizing that this can be very sparse data, because people don't collect the data all the time, recognizing that there can be erroneous data. For instance, the recognition that it's erroneous data has led us to do some feature. So for instance, we also include, we do what we call feature engineering. We include exponentially weighted moving average of the blood pressure numbers. See, if we don't do it, if we just use the blood pressure numbers, historical blood pressure numbers, the accuracy is not that great. So that indicates that understanding the trends is important, because this data can be erroneous. And when you put in the trends, it improves the results. Similarly, the other thing I mentioned is the sparseness of the data. So the high dimensionality of the features versus the volume of data means that there can be a lot of errors. And the way you, there can be overfitting. And the way you address them is by doing very, very careful feature selection. So we have learned a lot, and we have designed our machine learning models, if you will, in the right ways. And I wanted to show you that the benefit is twofold. One is that, so this one individual, that is another individual. What we are pointing out to individual one, so we have listed here some of the factors, calories burned, steps, etc., etc. And what we are pointing out to this particular individual, that the number of minutes of active time and the number of minutes of awake time during sleep are the most important factors influencing his or her blood pressure. Whereas the user 2, if you look at the chart over there, the minutes of sedentary time and the number of awakenings during sleep seem to be affecting their blood pressure level the most. So different factors are affecting different people differently, and thereby, and this gives us the ability to provide personalized recommendations. Also, we can see that for the same values, for the same values of the parameters, different people will have different predicted blood pressure levels. So that is also an interesting and useful thing to understand. We are comparing here a lot of things, but what I'll just say is that our final model has very acceptable mean error, absolute error. So for systolic and diastolic, these are all blood pressure modeling I was talking about. Systolic and diastolic, it's about 4.31 and 5.64, and which is significantly, 5.18 and 4.30 in terms of MAE, which is quite acceptable, I think, but we'll know much more, and I'll tell you a large study that we'll be conducting. The other thing I wanted to note is that most of the studies up to now has been on aggregated data, so recorded data at the county level and so on. There's a huge benefit of collecting this kind of personalized data using all these new devices. Why? Because if you look at it, so this is for the same data that we have collected. Is this the laser? Yes. So if you look at, if we aggregate all the data, then the mean absolute error, if we aggregate all the data and then create the model, the mean absolute error is much more than if we create personalized models for each individual. And the same for systolic as well as diastolic. So this is indicating that this kind of methodology, that is continuous collection of data and creating your own individual models, is more effective than creating these very, very large data sets and then creating a single model from that much larger data. And now so we want to eventually commercialize this. That's our goal, and any projects that we take up, we want to put it to the hands of people. So there are some important aspects here, and that is, imagine someone is using this system, starts using it, and he or she has to wait for 3 to 6 months for the data to be collected, right? Instead of that, if you can apply transfer learning, what that means is we try to match your characteristics with someone else's characteristics and start using that model and using online learning techniques, and I know that I'm using some jargons here, using online learning techniques essentially learn better and create a personalized model. So that's our approach going to be.
Somebody is typing very loudly. If you could maybe mute your phone.
I'm not being able to advance.
Or you're not able to advance the slides?
Oh,
Should I be clicking?
Try it now.
Oh, okay. Okay. And just very, very preliminary data. This is very, very preliminary data. So what we did was we wanted to know, what is the effect of these personalized recommendations. So we went back and randomly chose two people of the number of people that volunteered. And we asked them, we just told them that these are your top features. So for person 1, we told that these are your top features. Person 2, we told them that these are your top features. So for week 1, they continued doing what they were doing. And week 2, because they were told what those features were, it was left up to them to make adjustments in their exercise patterns or sleep patterns and so on. And if you look at it, for person 1, it was quite effective. The blood pressure levels came down quite significantly from 130 to systolic came down 130 to 110, and diastolic came down to from 82 to 70. For user 2, the effects were not as much, and either because these can point out to 2 things. One is that yes, we are giving personalized recommendation, but recommendation is one thing and intervention is another, right? They may not know how to deal with that recommendation. So that might be one factor. The other big factor might be the lack of nutrition. Maybe in this case, though we are thinking, our model is thinking that these are the top features, and they are the top features, but if you put nutrition somewhere in the mix, then maybe nutrition in this particular case would have been even a bigger feature, for instance, salt intake, right? So we don't know what it is, and so what we have seen is that for some users it's being very effective, and some users it's not as effective. And there are many list of things that we need to do, but I keep emphasizing on this missing food intake. It was good to hear that exercise is an important thing, because from your community, but one of the things I wanted to maybe mention is this study that we are starting. We have got the IRB approval. It has been a long run process, and we are going to start the study in March. So essentially, the previous study was more volunteers. This is going to be real patients selected using some criteria. This would be pre-hypertensive patients, 140/90, BP less than that, without any medication. And we are going to have 3 groups. One is a control group. We just collect data and we don't give them any feedback. The second group, we collect data but also give them this machine learning feedback. And the third group, our physicians are going to actually create personalized interventions for them. And we are going to compare and see how these groups do. We are using various kinds of devices. We are keeping it very, very simple, easy to use. Let's see, and the goal is essentially to understand the effect on BP of these personalized contextual recommendations and patient behavior change. I'm very, very interested in this second question, and that is, can we keep the pre-hypertensive patients off medication? Can we encourage them to do change as much their behavior and keep them motivated and keep them off medication? Now, there might be a bias in this study because those people who will be volunteering in our recruitment drive might be very interested in this, and that's why there might be a higher possibility of having them do all the right things in terms of complying with the recommendations and so on. But I'm sure we'll find out also people who are following the recommendations and yet we might not be able to keep them off medication, and we'll see.
Just one clarification, in the third group, I see that their provider and their, I guess they're somewhat personalized, but are they somewhat standardized also depending on some of their numbers? Like, you don't know what the physician's
The groups are will be selected totally randomly.
I know, but the recommendations.
Oh, the recommendations. So the group, the
somewhat?
interesting question. Group 2 will just give them the system feedback, right? That these are your top features, top factors. But group 3, their physicians will get to look at those features and discuss with them, and
You don't know what it will do.
no. So for instance, we have discussed some sort of things. For instance, if let's say a feature is number of awakenings. If someone tells me reduce my number of awakenings, I don't know what to do, right? However, a physician might be able to sit down and say, let's do a sleep test on you. Let's see if sleep apnea is an issue. So it's essentially, but the doctor will know that these are the top features, and let's hone in on those features and sort of provide some intervention techniques based on that.
You don't know if they would give them diet recommendations, for example.
So that's the whole missing part here, and that's why I'm here. That we are not being able to measure diet. However, in this study, what we are asking is provide any contextual things, like either a very stressful day, or a very day with a lot of outside eating, some vague things like that, right? We don't know how to incorporate that yet into our machine learning models, but at least we want to collect the data, and we are really looking forward to working with you to incorporate nutrition data into this kind of study.
What kind of data do you really need from nutrition?
What kind of data? So, for instance, that will depend upon what we are looking at, right? So, for instance, for blood pressure, we know from common wisdom that salt intake, sodium is an aspect, potassium is an aspect, right? So now I know that we cannot measure salt intake per se or potassium, but what we are hoping is that we can see, depending upon what they are eating, if we can at least have a record of those, and then using some technology, if we can, even things like you're having this much soda, or you're having this much, even see, having categories of things and having them as features can still be useful, because for instance, so for instance, since PepsiCo is here, I'm just saying this, that if we can record that are they having soda, and if we see that soda doesn't appear to be the top feature, if you're just having soda as a feature, right, and if we see that soda doesn't appear as a top feature, then that means that that person is not affected by soda. Maybe someone else, soda might appear as a top feature. So what I'm also thinking is that it may not be that we need to really know the exact calories or the exact salt intake or the exact potassium intake, but rather what kind of things they're having into some categories, and then use those as features. But that's an open question for us. We don't know how to proceed, and would love to get your feedback.
You need a nutritionist.
Yes, absolutely, absolutely. That's what is missing in our team, definitely.
That's why he's here.
Sorry.
Well, I guess I was going back to your slide where you did the comparison of one that responded and the other didn't respond. In a sense, the one who didn't respond was normal. So you wouldn't have wanted your machine to somehow say that an intervention was needed to reduce blood pressure below 100 systolic. So therefore, I don't think that example, I think in a sense the machine learning was correct.
I see what you're saying. I see what you're saying.
Because you have to differentiate.
I see what you're saying. And that in some sense, I totally understand what you're saying. Maybe it's not possible to reduce anymore, maybe because it's already pretty normal, right? And this was the weakness of our study, because these were volunteers that we had. Now the next study that we are launching, that will be more interesting in terms of data, because those are all going to be pre-hypertensive patients. And there, the conclusion I was trying to make, that maybe there is some factor that is missing, or maybe it needs, he or she needs intervention as opposed to just recommendation, would be more applicable. I agree with you.
So I thought that this was a positive side if you had spun it that way rather than
Right, right. It's I guess by scientist mind thinking that why wasn't there a good result there?
But I mean, in this case, you wouldn't necessarily have wanted
Right,
to
right.
potentially.
Might be. So if I may just quickly, I just wanted to, I'm not going to, talk about this slide, but we discussed data privacy, important factors, right? And what we are trying to design is a system where that the healthcare provider will have the ability to either have data stored just on the edge devices, and all the AI techniques are done at the edge devices, which is a tall order, but we are trying to. Or it might be all in the cloud, or there might be a mix of both. And so we are building using software-defined networking principles. And as you know, the edge devices are becoming more and more improved. There'll be much computing in the vehicles, of course, on your on your mobile device and so on. So we are hoping for this mixed paradigm where data can be, yes, data is collected by the edge devices, but the processing, the storage, all these things can be mixed. We call it a hybrid approach, and I'm not going to go into details, but it has ramifications in terms of security, different kinds of database. For this kind of work, that's why, for instance, I'm also engaging with people who are developing various kinds of database techniques. It's a very multidisciplinary research which touches various different things, and of course, 5G technologies will help in enabling all this. I just wanted to give you a very, very quick flavor. Can I take 2 more minutes? I don't know how much I have exceeded.
You're good.
Okay. So the march towards using these new technologies continues in various of our projects. In this project, we are trying to enable now the spirit of our connected health program remains the same, and that is enable virtual techniques. So virtual healthcare techniques. So here, what we are doing is we don't want to replace physical therapists and other healthcare providers. We want to supplement them. So what we are doing is we are working with our physical therapist clinics and colleagues to record what is going on using various kinds of sensors. So for instance, this Parkinson's clinic here, and the Parkinson's patients are coming. They are being guided by the physical therapist, and we are recording those. And through those recording, we are creating what you can call a virtual physical therapist. A virtual physical therapist not only just looks like this individual, so that's just the looks, but rather acts and behaves like this individual. What that means is, the physical therapist has a lot of subjectivity in him or her, and we are trying to capture all those subjectivities. So for the same kind of patient, they may provide different guidance, and we are trying to capture those differences. And then what we'll have is a virtual physical therapist, and wherever you are, be you in hotel in Washington D.C. or somewhere else, you would be able to follow the virtual physical therapist as an avatar, and as you are following him, the virtual physical therapist is also following you and is constantly noting how you are doing, using pressure sensors, using connect sensors, and using skin-based epidermal sensors. And so these are, again, we are having our faculty who are developing these sensors, work together, and this system that we have developed essentially then it doesn't replace the physical therapist, but you will be able to supplement what you are doing when you are going to the clinic when you are not being able to go to the clinic, or if you are a mobility impaired patient, like a lot of Parkinson's patients, stroke patients are, you are not forced to come to the clinic. This will, we think, expand care. It will have virtual physical therapists always available on demand, and very, very personalized recommendations, because as you are performing, the virtual physical therapist will be able to see where you are going wrong and then give you guidance exactly where you are going wrong. And the results have been pretty good so far. Our patient population is not yet as large as 35 Parkinson's patients. It has been quite a lot of work to monitor the patients and sort of record everything. And Accuracy at this time, it's getting cut off a little bit, but about 91%. We are not completely happy with the accuracy levels. We want to improve them, and so we are keeping on developing new techniques to improve them. But the direction of the research is going quite positive. And lastly, I wanted to very, very briefly mention this project is being led by my colleague at School of Medicine, and there are various other people involved. But this is the kind of thing that I'm hoping you'll get to see not only from UC San Diego, but many other places, and that is going where things were very, very abstract and not quantified. So mental health has been a place where many of us might have experiences, not necessarily of our own family members, but of friends and so on, who had issues, who needed help, but it's very, very unquantified. Definitely to an engineer, it's like it's very vague. What the recommendations given to you are, and what we want to do is we want to demystify it. We want to quantify. We are doing a broad net: attention deficit, anxiety, depression, cognitive impairment. I have been working with Japanese life science societies, and they are encouraging us to look at dementia because that's a big, big problem in Japan. So what we are trying to do is collect data of mental health behaviors and life experiences, but brain and cognitive function, stress response, epigenetics, and lifestyle health behaviors. Again, at this time, we are restricted to exercise and sleep, but we want to expand it to nutrition. And essentially, through data and data sciences, quantify answer the question, is it attention deficit or is it depression? If it is depression, what level of depression? And so essentially, we are trying to create personalized prediction models and again identify the important factors that might be influencing a certain person. And then if we are, and that's a tall order, we have just started this whole research. If we can, then we'll be able to recommend. So many of our faculty members in the team have been doing various brain training, games and exercises. So we can recommend those games or exercises. We can recommend the right kind of sleep, the right kind of activity, and so on. So the personalized interventions can be built on what are the different factors that are contributing to a certain person's mental health behavior or cognitive impairment progress. And so I'll stop here. I just wanted to, so this is a very, so this program, as you see, is looking at various different kinds of things, from blood pressure. We are also looking at diabetes. I didn't mention that. To mental health, to physical therapy. And every time thinking of how to quantify using data sciences, using data, how to figure out personalized reasons, and then provide personalized intervention techniques or recommendation techniques. And as I mentioned, that we do believe that that we need to consider food intake in developing these models and providing these personalized recommendations. The effect of food intake, obviously all of us know that the effect of food intake and the type of food intake may vary in a very personalized way. To me, certain kind of things might not affect at all, and to others it might. And we believe that we'll be able to, if we can incorporate it in even loose ways, not very accurate ways, we'll be able to find out much more about those effects of food in our frameworks that we are developing. Thank you.
I think Sujit proves my point that nutritionists need to listen more to engineers than other nutritionists about this issue. That was terrific. Thank you.
Thank you.
And any comments, or we have time for just a couple of comments and questions, John?
Thank you. It was very interesting, particularly when you got into some of the medical applications. I was at a conference yesterday at National Institutes of Health on spinal cord injury patients, and there are many problems. And one of them is pressure ulcers, and the whole business of monitoring your blood pressure and everything there. The costs of these patients are enormous. Their suffering is also enormous. Most of them die of septicemia or pneumonia or suicide. And a lot of these devices are designed for healthy people, but these people are going, there are about 200,000 of them in the United States. They're going without much help for these very simple problems. Pressure ulcers are not something we don't know how to treat. And I wondered if you've been looking at that population. Another population is hemodialysis patients and their blood pressure problems and monitoring them. Do you know of anybody working on these problems?
No, I think we definitely are not working, but I can personally relate to it because my own dad, and I was with him for 5 weeks at an ICU, and he had multi-organ failure, and then had to be done dialysis, and the problem was with blood pressure, and so in that context, they had to slow down the dialysis, and eventually he got sepsis, and that was the end of it. So I have been discussing with colleagues in Kaiser. They are very, very interested. We have not been able to do it essentially, but hearing from you, I will definitely like to think about it more and even discuss with you more. I think that we can see, the good thing is that we have access to our physicians. They are very interested in using the modern technologies. So that has had a huge change in the last 10-15 years, and they are much more open today in working with us. And so we can definitely focus on this kind of patient population and see what we can do with the modern technologies and with data. Yes.
I think just kind of listening to your talk, it raises a question in my mind. It's not necessarily directed maybe just to you, but to the group or something to think about as we're moving forward. You talked about, you admitted the good to include nutrition in this. And I think one of the challenges with all of this is that, first, as we're thinking about these problems, who are the right people that need to be in the room? Then second, like within each discipline, having enough of understanding about where the potential risks are. I was, a while ago, I was talking to somebody that had an analytical services company. They were telling me what a great job they can do measuring plasma, potassium, and sodium. And we had a really interesting back and forth about why that's not going to be useful. Although their data was great. But so it's sort of so understanding the right measures, understanding the the variability that live under those measures. Because at the end of the day, if I understand, to the extent that I understand modeling, which isn't very well, it's all based off of the initial framework and construct. And not that you can't learn things as you go along, but you have to have how do we get the right people in the room? How do we understand we have the right measures? We understand the variability, and we also have this other interesting thing about our current regulatory framework. The Internet of Medical Things. Is that truly medical, so like medical devices, or is it things that can be targeted to the consumer? I know at one of the earlier meetings I mentioned this. The reality of it is that a lot of these devices could run across both, but we have a regulatory environment that necessitates a divide for some very good reasons. But as we think about these approaches, we need to think about how we can be more how we can be more flexible with respect to the tools and techniques that we can apply.
I totally agree with you, and that's why the value, and as David had so correctly said in the very beginning, for us to have these interdisciplinary communities to discuss and figure out. So too much data, just feed everything is not a good approach, and we have seen this again and again in various other aspects of data science. I practice in other areas, and sometimes it just leads to wrong results. So you're absolutely right. Setting the framework is correct, and so what data to feed into that framework is very important.
And doesn't that go back to the question you're asking? Because what question are you asking? Research question you're asking will determine what data set and what discipline to bring in for the initial meeting.
Yeah. The issue with that, though, you're right. The research question should be part of the frame.
Right.
But we we all come, not intentional, but, we come with our own bias based off of our training. Nutritionists will see things from a nutrition angle. An exercise physiologist might see it more from activity expenditure, and I'm saying I think that, I think we continue to get better at collaboration, but we're not there. We're not there yet. And even more damaging is sometimes people will overextend themselves. They have training in this area, I'm a scientist, I'm a physician, so I have expertise across all these, and that can also be damaging as well.
I think we should just continue this discussion in the afternoon session. We do need to move on. Thanks
Thank
very
you.
much.